Globally, 600 million people suffer from chronic lower back pain alone, and that figure has risen dramatically just over the last 2 decades.
So pain is a decision made by the brain. And how do we know that? Well, we know because millions of people have had injuries and have no pain.
Specialist in treating chronic pain, Dr. Howard Schubiner.
There's one amazing study where he looked at the U.S. after 9/11. Indicators of stress in this society went up significantly in the whole society, and the incidence of back pain went up in exactly the same way. So we did this study in 222 people, and we determined that 88% of them had non-structural pain. 88%. And it just doesn't make sense. And this is a revolution in thinking about pain and understanding how the brain works. And why would the brain create pain in the absence of an injury? It turns out that the way our brains are wired is that stress and emotional upset activate the exact same parts of the brain as does a physical injury. We know that people who've had childhood trauma have much higher rates of the whole variety of illnesses in adulthood, including chronic pain and anxiety and depression and substance use disorders and eating disorders, etc. There's several things that can happen when people have had trauma in their lives. One is
Hey there, friends. Welcome once again to the Happy Habit Podcast. I'm Matthew. You'll find me here every Monday and Thursday talking health, well-being and self-improvement with many, many experts, people of interest. And if that is your thing, well then show your support for the channel. Please like, subscribe, share with other people who you think might get value, and be interested in these episodes. Leave the podcast a positive rating, which you can do on iTunes and on Spotify. And if you're over on YouTube, you can become a subscriber there and leave a comment there too. We're almost up to 400 episodes now, so feel free to check out some of the many, many episodes of interest in the archive. And again, it is absolutely free to do so. Now, chronic pain is an enormous problem across the entire population of the world, and anyone who has experienced pain beyond a period of several days will attest to its debilitating effects on their life. Existing pain management models are exactly that. They are pain management models, and this can involve years of prescription pain medications, which will bring their own issues and negative health effects. So today I speak with a pain specialist and author of the book Unlearn Your Pain, Dr. Howard Schubiner, who has developed a pain model to help treat patients with chronic pain, not by managing the pain, but in many cases by eliminating it entirely. In this episode, we define what pain is and learn that pain is in fact processed in the brain. We hear that in many, many cases, pain exists in the absence of physical injury or structural anomaly. Discover that with chronic headaches, for example, in most cases, there's nothing physically wrong with the sufferer. We learn of the relationship between the growing prevalence of back pain and the rise in anxiety and depression. Expect to learn of the link between poor self-image and chronic pain. We also discuss the connection between childhood trauma and illness in later life, including the presence of chronic pain. We also hear about the research studies Dr. Schubiner and colleagues have been carrying out, which shows that chronic pain can be eliminated without needing medication. Dr. Schubiner is a pioneer in what can only be described as an extremely exciting and potentially transformative area of medicine and healing. I really hope you enjoy this fascinating conversation. Well, let me start out by giving a stat. Now, this stat blew my mind. I found it while I was researching for this interview. Globally, 600 million people suffer from chronic lower back pain alone, and that figure has risen dramatically just over the last 2 decades. And we know this then has a knock-on effect for people's productivity, which leads to a burden on entire economies. So I'd like to start out by finding out what your take is on this generally, and then why has the problem of chronic pain become worse in recent decades?
That is a great question. Physicians and scientists are at a loss to figure out why, and it's true, exactly what you said, that back pain has increased dramatically. In the U.S., it has doubled. Prevalence of low back pain has doubled in the past couple of decades. And it's not because there's more old people in the society, because the prevalence of back pain is primarily in the 30 to 50-year-old age range. It's not because people are exercising more or exercising less, or because they're backpacks, or because they're on computer screens more. It's not because our backs have evolved somehow or changed in the last 20 years. And so no one really knows. We do have some data. There's an economist named Timothy Brown at UC Berkeley who has one amazing study where he looked at the U.S. after 9/11. In the year after 9/11, indicators of stress in this society went up significantly in the whole society, and the incidence of back pain went up in exactly the same way. And then a year later, the stress levels started coming down in the society, and the back pain levels started coming down in the society. The other thing that's gone up dramatically in the U.S. and worldwide is anxiety and depression over the last 2 decades. And that, in my view, is not a coincidence. We're seeing higher levels of stress due to a whole variety of things, globally, socially, economically, you name it. And that has translated into higher levels of anxiety, depression, and back pain, and headaches, and fibromyalgia, chronic widespread pain, and pelvic pain, and abdominal pain. So there's a whole range of disorders that I specialize in. That's my work. My life's work is doing this for these people who I love and care for. And it's because our brains create a danger signal when our brains feel in danger. And we can talk more about that. But in my view, that's the underlying issue. And it's kind of counterintuitive to what most people think about. Oh, well, did I pull my back? Or am I getting old or whatever?
Okay, so to summarize what you've said there just at the outset, that in many cases you don't believe that pain is related to anything we're actually doing. It's not a behavioral thing. It's not like we're sitting with poor posture, because we are sitting a lot today. But what you're suggesting is that the physiological anomaly which medicine thinks exists in a lot of cases isn't actually there at all. And so there's no physical anomaly as such. There's no physical disorder. And you're suggesting that the pain is originating in the brain because the brain processes the pain, and that's where it comes from. And so that's where the confusion comes from, I think.
That's correct. Now, it's not 100%. I'm not saying 100% of pain is due to the brain, because certainly people can have a tumor in their back. They can have an infection in the back. They can have an autoimmune inflammatory condition. They can have very huge, large bulging disc pressing on the nerve. Those things can happen, and they certainly do. And it's the same true for all levels of pain. Anyone's job, my job as a physician, all physicians' job is to look for any medical, physical, structural problem first. That's job number one. But we just published a study in the Journal of Pain last month where we took 222 people coming into a physiatry or physical medicine and rehabilitation clinic. And these 222 people had chronic neck and back pain. And we evaluated them using our model of evaluation, which looks not only at the back, not only at the MRI, but also at what the pain is like. And if the pain shifts or moves or turns on and off, if the pain has characteristics that allow us to rule in that it's actually caused by the brain. And when we did this, and all of these people's MRIs were abnormal. And this is the thing that most people don't understand. And, why would you? But doctors don't really get it either. Because basically, as we age, our MRIs become abnormal. Just like our hair becomes gray. Just like our skin not in you, but our skin gets wrinkles. And what happens is that the MRI starts to show degeneration, bulging discs, some arthritis. All these things occur in normal people who have no pain. So to assume that you can tell the cause of a back pain on an MRI is really a faulty logic. So we did this study in 222 people, and we determined that 88% of them had non-structural pain, 88%. And if you're a regular person with low back pain going to a regular doctor and you get an MRI or an x-rays of your back and they're abnormal, the doctor 99% of the time is going to say, oh, we found the cause of your pain. Your back's like an old person. Your back's degenerated. Your back is weak and all that. But they're giving you findings. It's like saying the cause of my headache is my gray hair. And it just doesn't make sense. And this is a revolution in thinking about pain and understanding how the brain works. And we have I can tell you about randomized controlled trials showing that our method actually works to help people reverse or eliminate their pain as opposed to simply saying you have to manage it.
We'll come to the model of treatment that you espouse in a moment because I want to flesh out the existing models that are more conventional, quote unquote, models of treatment in a second. But you made a very interesting point before. You said that not all injuries cause pain and not all pain is because of injuries. When we're talking about pain, what exactly is pain, if you can define it for us?
Yeah, of course. Pain is an experience that is generated in the brain, which is unpleasant, usually. It's an experience that's generated in the brain, and it's triggered by a kind of danger alarm mechanism in the brain. So when you touch a hot stove, the receptors fire in your skin, the nerves send signals to the brain. Mind you, these are not pain signals, they're danger signals, if you will. Because those signals don't carry pain. They carry this kind of impulse, and the brain has to interpret, is that pain or not? The brain has to decide. So pain is a decision made by the brain. This is a revolutionary statement. It's true. And how do we know that? Well, we know because millions of people have had injuries and have no pain. So if you can have an injury, and many people have experienced this, and there's research showing this, if you can have an injury, you can have a nail in your hand, you can have a broken this or that, you can have a big cut or gash and have no pain at the moment, it's because the brain has decided something else is more important. And for whatever reason, and when I say the brain, I'm talking about these subconscious structures that we don't have control over. You can't cut yourself and say, oh, I'm not going to have any pain because I don't want it. Well, you can't do that because it's your subconscious brain that's telling you, you cut yourself, that hurts. So the simple fact that not all injuries cause pain tells us that the brain is in control of pain. So that's one point. And the second point that you brought up is really important. Not all pain is due to injuries. And so again, there's tons of data on this, and it's been shown very widely. But the simple story of the guy in Britain who was a construction worker and jumped down from a scaffolding, he impaled his foot onto a nail. The nail went clear through his boot, all the way through his boot. He screamed, yelled in pain, writhing in pain, rushed him to the hospital. They give him pain medication. And you know the end of the story. What happened is they took his boot off and there was no injury at all. The nail was between his toes. But the point is, his brain saw that and his brain created pain. And that pain was real because all pain is real. There's no such thing as fake pain or, unreal pain. I mean, certainly somebody can say, they can say, oh, I have pain when they don't, but that's rare. We're talking about people who have real pain. And the question is the pain coming from an injury or is it coming from the brain? And why would the brain create pain in the absence of an injury? It turns out that the way our brains are wired, this is again just a fact, the way our brains are wired is that stress and emotional upset activate the exact same parts of the brain as does a physical injury. So if someone sees a nail in their boot, or someone is having a really hard time with a spouse, a child, a boss, a neighbor, something's going on in their life that's extremely difficult and weighing on them, the same parts of the brain will light up as if they had a physical injury. So that if you get headaches after a stressful day, if your stomach turns into knots when you have to give a public lecture, those are signs that the brain is causing a physical reaction. And those physical reactions can be severe, can be 10 out of 10 pain, and they can cause chronic pain. And that's what we do. We help to determine if someone has a structural injury or not, or a combination. Sometimes it's a combination of the two. In our study, 88% had non-structural pain, 6% had combined pain, 6% had purely structural pain, in our view.
Let's talk about the current modes or models of managing pain. I think we all know people who have been on pain meds for months or even years at a time, and this comes with its own problems. What are your thoughts on the status quo of pain management, which encompasses several pain management models? And then if you could introduce us to your own pain management model too.
Yeah, of course, I'd love to. Thank you so much for having me, by the way. It's a pleasure to talk to you. Well, first of all, the idea of pain management, just the word, the term, right? It's suggesting that the pain is chronic, will be persistent. We're going to manage it as opposed to eliminate it. And obviously, that's not what people want. If you're suffering, and the people that we see are suffering greatly, they're great people. They're suffering mightily. Their lives have often been torn asunder, devastated, uprooted. They've been forced into isolation and withdrawal because of this chronic pain, whether it's in their head or their neck or their back or their chest or their stomach, pelvis or wherever. And we're telling them the typical traditional medical model, saying, well, we can't cure, we don't know why your pain is there. We know it's chronic. It's a combination of the body and the brain. We can help modify it, but we can't resolve it. We can't reverse it. And then the idea then is to try a variety of things. The multimodal treatment model, which is the one used by the vast majority of major pain centers around the world, which is a combination of medications, injections, sometimes surgery, acupuncture, talk kind of therapies to help modify the pain, and physical therapy, of course. And putting those all together, we can help manage it. It's a team effort. But that model has not really been effective in eliminating pain. And so we're looking at how can we change the wiring of the brain? How can we change the neural circuits of the brain to make the pain go away? And we have, as I mentioned earlier, we have several randomized controlled trials showing that our model, and I'll describe the model in a minute, but that our model can help reverse or eliminate pain in approximately 2/3 of the people who use it, which is incredible compared to the standard model, which is modify or manage the pain. And nobody can claim that their whatever treatment they have is 100% effective. Ours is certainly not. But we're seeing really, really remarkable results. And I've been doing this for 21 years, and there's nothing better for a clinician, a physician, a therapist, a physical therapist. We're training all sorts of folks to do this work, than to have the patient come back and say, I feel so much better. Thank you. My pain is going away. It's gone. I could never have believed this was possible. No one ever told me this was even possible. You saved my life. And when, how can you not feel so gratified when people tell you that? I mean, I get emails from people who tell me that just by reading some of our materials, some of our books. I got an email yesterday from a guy who had chronic fatigue, not pain, but chronic fatigue, which is another area that is commonly caused by neural circuits in the brain. And he said, I read an article you wrote on chronic fatigue. I ordered your book. I started reading it. My God, I was better in a week. I couldn't believe it. I've been suffering with chronic fatigue for 3 years. I couldn't walk around the block. So the model that we use is really, it's different. It's counterintuitive. And some people really don't understand it or don't get it or think that we're saying somehow, of course, that it's all in your head, right? When people hear that it's in your brain, they immediately think, oh, it's in my head. Are you saying I'm faking it? Are you saying it's not real pain? Are you saying it's my fault that I want the pain, that I've done something wrong? And none of that is true. None of that is true at all, because these structures in the brain are involuntary, and the pain is real, because all pain is real. So we really need to convey that to folks, that this is not a model that's blaming them or saying that they're weak or mentally crazy or anything like that.
Let's talk then about your own model, and this is called the symptom perception model. And when it comes to helping chronic pain sufferers, and there are some fascinating stats out there. But could you talk us about what the model encompasses first of all, and then about its efficacy as far as pain management is concerned?
Yeah. Well, the you brought up is really wise of you to say this. The old model of understanding pain is the biomedical model, meaning that there's an injury in the body and the brain is just reflecting that injury. Descartes came up with that in the 1600s. So the biomedical model, and that can work if you have a fracture, you fix the fracture. That's fine. You don't need to invoke what's going on in the brain. The major model in the world now is the biopsychosocial model, whereas there's some biological components, psychological and social, and you put it all together. And that works well for disorders that have a physical problem, plus the brain may be amplifying the pain, such as someone who has knee or shoulder arthritis. But the symptom perception model is the one we use for people who have disorders that are called nociplastic, meaning that the pain is real, the pain is coming from the brain, and it's not due to a structural problem in the body. So we call that the symptom perception model. And the way we treat that is by using an approach that first educates people on how the brain works, that the brain is the source of pain, and that stress and emotions can cause the brain to create real physical pain in the absence of structural problems. The second component of that is a complete and detailed assessment, such as we did in that research study that I talked to you about, where we look at each individual. We don't just assume, no one should ever assume that someone's pain is totally in the body or totally in the brain without a careful evaluation, without medical testing to make sure there's no structural problem, and without the kind of evaluation where we look carefully at where the pain is, how does it shift, how does it move, what is it triggered by, etc. And that's usually pretty easy to do, but it's a critical step. And then we explain all this to the folks who have pain, and we see if that makes sense to them. And if they need more evidence, we get more evidence. We take our time with people, and we care about them, and we show that we care about them. So that's the first two steps. But then once we've agreed that the pain or the symptom, whatever it is caused by neural circuits in the brain in the absence of physical injury, we have two major methods, therapies that we use. One is called PRT, pain reprocessing therapy. And the other one is called EAET, which is emotional awareness and expression therapy. The first one, the PRT, pain reprocessing therapy, is designed to reverse the neural circuits in the brain. And it is based on the idea that what fuels the ongoing, one of the things that fuels the ongoing pain is fear of the pain, focus on the pain, worrying about it, paying attention to it, being frustrated with it, and fighting it. And so what we help people do, and again, it's counterintuitive, we help them explain to their brain that they're okay, that they're safe, that they're not in danger, that this pain is kind of a false alarm. It's like a smoke alarm that their brain is sending out of danger, but the smoke alarm is set a little too highly sensitive, and they can safely begin to do the things, and we teach them how to do the things that have triggered the pain with a completely different mindset. And it's amazing how powerful that simple model is in literally turning down and then turning off the pain. So that's the PRT. The EAET works on the emotional side. It's emotional awareness and expression therapy. And what we're doing there is we're helping people to identify the feelings that may, and not everyone needs this part of it, by the way, but the feelings that may have triggered the pain or are continuing to trigger the pain in the first place, such as a conflict with a boss, with a spouse, with a neighbor. We saw a woman just the other week who had found out that her husband was having an affair on her, and her pain level rose up, her back pain rose up to high levels. And she And she confronted him about it, and she talked to him about it, and she told him how angry she was. And he agreed to go get counseling. And doing that act lowered her pain dramatically, immediately on the spot. You can see often the strong relationship between emotions and pain. And sometimes the emotional issues even date back all the way to childhood. So we deal with some of the trauma and the issues that have caused the brain maybe to be hypersensitive in the first place. So those are the two main treatments that we employ.
We'll come to childhood trauma in a second, but I want to go back to PRT because you said that part of the treatment involves reframing how people view their pain. And I was reminded of a conversation I had with an audiologist last week on the podcast here who was treating people with tinnitus, and he used cognitive behavioral therapy in order to get people to reframe how they viewed the noise and the ringing in their ears. So it's very same.
It's similar. Cognitive behavioral therapy is a good therapy. Acceptance and commitment therapy is a good therapy. Mindfulness is a good therapy. Those are the three main psychological therapies that have been used for chronic pain and tinnitus and these other conditions. But those three processes in randomized controlled trials have only showed small effects on chronic pain. In our treatment, it actually has shown much larger effects on chronic pain. And we've done trials, and we're doing ongoing trials now. We're actually comparing our treatment model to the CBT model and the ACT model and the mindfulness model. And the difference is that our model starts with an understanding that it's the brain causing the symptom and that it can be reversed. And if you start with that model, then the techniques may seem similar. They're not exactly similar, but they're quite similar, certainly. If you start with that model where you truly understand that it's the brain causing the pain or the other symptoms, that it is reversible, that these treatments are geared to completely reversing it, as opposed to, as CBT tends to do, and that can change depending on the individual giving it, but as CBT in the world of chronic pain is geared at, it starts with the idea the pain is caused by unknown reasons that we can't cure, and we will help you to cope with them better. That's a big difference. And so when you start with our model and you use these techniques, people are much more likely to have reversals of the symptoms as opposed to small decrements in them.
You mentioned it there. Talk to me about the nervous system and the relationship it has in the present with childhood trauma from our past.
Yeah, it's a really important question. We know that people who've had childhood trauma have much higher rates of the whole variety of illnesses in adulthood, including chronic pain and anxiety and depression and substance use disorders and eating disorders, etc. What happens is, and this is well known, that childhood trauma changes people's brains. It sets their hormonal milieu differently. It sets their danger signal, the sensitivity of the danger signal differently, and it predisposes them for having other illnesses later in life. And a quick example of that is one of the very first patients I saw many years ago. She had a loving mother, and she had a father who was unpredictable. And sometimes her father would come home very nice and happy, and other times her father would come home in a horrible mood, yelling, screaming, criticizing her, grabbing her by her collar and yelling in her face. And that was her upbringing. And she grew up and she was fine. And when she was in her mid-40s, she got a headache, and that headache didn't go away for 17 years. Every day, chronic severe headaches. And no one could figure it out. And all the doctors, she saw many, many headache specialists, headache centers, medications, injections, everything anybody could do medically for her for these headaches. What could I do? Well, I could talk to her. And it turned out that the time that her headaches started was a time when she got a new boss. And her boss was exactly like her father, unpredictable, nice often, and sometimes extremely mean, cruel, demanding, and debasing. And that set her brain off because of the memories of what her father was like, was seared into her brain, and then the the mirroring, so to speak, of that kind of emotional trauma from a boss. And that set her brain into this danger signal, which caused a headache. And it became chronic. And she completely recovered from those headaches after 17 years of daily chronic severe headaches, because we identified the problem and we could help her address the neural circuits in her brain by the PRT work and address the emotional reactions that her brain had become used to or had been traumatizing her brain, so to speak, by the emotional processing work.
It's extraordinary. It really is. I'm reminded of another conversation I had with Professor Ellen Langer a couple of weeks ago, again on the podcast. And she has been talking about the mind-body connection for the last 5 decades. And she says that the mind-body is one entity, because if it isn't, then how do you explain how thoughts in the brain that are manifest then in the body? And you gave an example earlier about how people feel butterflies in their stomach when they have to give a public speech. The very thought of giving that public speech manifests itself as a physiological response in the body in terms of butterflies in their stomach.
One of the techniques that you just mentioned, first of all, Ellen Langer is a hero of mine, and I wrote a chapter in one of her books. I was honored to do that several years ago, and she's done amazing research and amazing contributions to this field. And you brought up something that is really interesting and that we use every day, and that is that the anticipation of giving a lecture can cause the stomach to turn into knots. And one of the techniques that we use every day is using that model. If the brain is anticipating something, it can turn on those neural circuits. And so if someone's having back pain when they bend forward, let's say, or is having foot pain when they walk, or is having dizziness when they stand up, we'll have them close their eyes and imagine doing that activity. Imagine bending forward, imagine walking, imagine standing up, and see what happens. About 70% of the time, they will get a physical reaction just to imagining the activity. And when that happens, their light bulb turns on in their brain, and we say, see, it's not the actual bending that's causing the pain. The bending is a conditioned response. Your brain is activating the back pain or the foot pain with walking because of the fear of the activity, because the neural circuits in the brain are being triggered by that activity. And then we have them give themselves some simple, positive, empowering statements to say, I'm healthy and I'm strong. And you know what? There's nothing wrong with my back. I'm safe. I'm not in danger. I'll be fine. And we ask them to smile and imagine now bending over with joy, or imagine to stand up with joy, or imagine to walk with joy and empowerment and safety. And then when they imagine doing that the second time, they don't get the reaction. The brain doesn't turn on the back pain or the foot pain or the dizziness. And they just change the neural circuit in the brain. And that is an entree. It's a very, very powerful moment that is incredible to work with folks. And then we have them start to bend over physically with the same positive mindset, to start to walk with the same positive, empowering, and joyful mindset. And their brain exists in a state of fear and danger or in a state of calm and peace. And you can see it in children. You know, when a kid falls off the bike, they look to the adult to see if they should cry or not. And if the adult freaks out, their brain goes immediately to that fear and danger state and they start crying. But if the adult says, hey, you're okay, you know, that was fun. You're fine, buddy. Let's try it again. Then their brain can shift immediately to a safe and calm and peaceful state, so to speak. And then they won't cry. And that's exactly what we're doing. We're working with these two states of the brain.
That's so true about children. I've remarked that before, that they fall on the ground, they look up and they seek their parents' approval as to, well, what should my response to this be? The concept of the brain being the seat of pain will be new to a lot of people who are listening and watching this. And in the book, you illustrate the influence of the brain over chronic pain by using the comparison with our ability to see, because we don't see with our eyes, you say. While the eyes accept light in from the world around us, it's the brain that puts together that image and processes that image, then interpreting it such a way that then we can understand that image. So
exactly.
I'm hoping that will help people to understand the significance of the brain when it comes to its influence over pain.
If you needed your eyes to see, you wouldn't be able to see in your dreams. I mean, it's a very simple fact, right? Our brain can make images, and our brain has to filter in and filter out billions of images coming our way in our eyes. You can't see everything that's there because you would be crazy. You can't see everything. You can take in the light, but our brains filter out and create what we see. And for example, if someone has seen a crime and they go into the police station or the trial and they point out the person who did it, they're likely to be wrong. This has been shown, in many, many research studies. And why is that? Because their brain is kind of interpreting. It's a quick thing. There's a stressful situation, and they're interpreting. And then what they actually think they saw is actually different than what they saw. And it depends on because what influences what we see is not only what comes in our eyes, but our memories, our impressions, our thoughts, what we expect to see. And so frequently our brains will see something that's not there. In the U.S., police officers go, carry guns. I don't know if they do that in Ireland. Exactly. So they go to a scene of crazy stuff, and it's very stressful. And they're trying to say, do I see a gun or not? And sometimes they can see a gun that's not there because of all the stress. And this is not uncommon. And so it's not uncommon in everyday life. If people think about their lives, do you hear things that aren't there? Do you ever hear your name being called? Do you ever hear words that are not what's being spoken? When my wife speaks, I don't hear what she says. I hear what I'm expecting her to say. Have you ever felt your cell phone vibrating in your pocket when it actually wasn't? I mean, millions of people have had that experience. So when we break it down to everyday experience, it turns out that our brain generates what we see, what we hear, and what we feel. And that is, as you said, a revolutionary statement.
So for the audience then, many of whom will have experiences with chronic pain, what steps would you advise them to take if they have been on this conventional treadmill of pain management with little or no progress to date?
Yeah. And my heart goes out to them. There's so many people suffering. It's a worldwide epidemic. Back pain is the most common, but it's also many, many other sources of pain. And the first is to kind of step back and say, well, what have I tried? What have I already done? Have I gone the medical route? Has it worked or not? If it hasn't worked, maybe they want to be open to a different approach. Have they seen physicians? Have they had testing? Maybe in the case of back pain, they've had testing and their MRIs are abnormal, but maybe if they look at their MRIs, they will see that their MRIs show the common findings that most people have, even if they don't have pain. So that may lead them to think a little more deeply and broadly about this. And then they want to educate themselves. So I've produced a series of 6 animated videos that are free on my website. And they're 5 to 6 minutes each, and they explain what pain is, how pain works, what the brain is, how the brain creates pain. They explain all this sort of thing. I also have a free course on the Coursera platform. It's called Reign of Pain. REIGN, of course, Reign of Pain. And that's a free course there's 17 videos, a bunch of lectures, a bunch of research data, materials that people can look at. There's an organization, a nonprofit that we have called the PPDA.org, the PPDassociation.org, which is our nonprofit professional organization, worldwide members who do this kind of mind-body work. And there's tons of resources on that website, again, that are free. There's a questionnaire there that'll also help people begin to think about some of these factors that they might have that might point toward a mind-body type of pain as opposed to a structural pain. So there's a lot of free resources out there. There's also a website called the TMSwiki.org, which is peer run by volunteers. In the UK, there's SIRPA.org, SIRPA.org, which is a really great, nonprofit organization with practitioners who do this work. So there's a lot of my website, of course, is unlearnyourpain.com, where there these links to the Coursera course and these 6 animated videos are, again, all free. And then, as you mentioned, there's books. There's a bunch of books. I've written books. Dr. Sarno is my teacher. John Sarno taught me this work back in 2002. He's now passed away, but his books are still selling. They're very influential. My friend Alan Gordon has a great book called The Way Out. My friend David Hanscom has a book about back pain. So there's really a tremendous amount of materials. Once you get into the Googleplex, they're easy to find.
And your own book, Unlearn Your Pain, we can pop a link to that book in the show notes for this episode. Can I revisit a subject that we spoke briefly about earlier? We were talking about trauma. There's a really, really interesting relationship between pain and poor self-image. Could you talk to us about this?
Well, one of the things there's several things that can happen when people have had trauma in their lives. One is they begin as children, they have to adapt to those situations. If they're being neglected, they need to look for praise. If they're being abused, they need to hide and run. They need to protect themselves. If they're being criticized, they start to learn that they need to try extra hard to be perfect. So these kinds of personality characteristics can develop over time as an adaptive mechanism, but when they grow up, maybe they're not quite as adaptive. So overly perfectionistic, overly caring about what everybody else thinks about them, never standing up for yourself, of feeling guilt all the time, like you've done something wrong, having a low self-esteem, as you mentioned, having a hard time being compassionate to themselves. So many of our people that we see, they're incredibly good at being compassionate to others, but it's hard for them to take a compliment, hard for them to be compassionate to themselves. And these traits of this overly conscientious, never putting themselves first, never standing up for themselves, all these kinds of things, feeling guilty all the time, create an increased sense of dis-ease or danger in their brain. And that danger, as we mentioned, can translate into pain or anxiety, depression, fatigue, insomnia, etc. Substance use disorders, eating disorders. And so one of the things that we almost always need to do is look at people's self-concept and how they treat themselves. And are they treating themselves as they would treat somebody else with kindness and caring, or are they being overly harsh or hard on themselves? And that changing that can make a huge difference in their pain. And I know this may sound crazy to some listeners, but if you understand pain comes from a danger signal in the brain, and if you understand that different things that can affect that danger signal, this is one of the most important ones.
So to recap then, just to simplify things even further, pain is often a manifestation of emotional distress that happens to seemingly locate itself in some part of the body. For many people, it's the back. But if we can treat the emotional origin and or reframe how we see that pain, then we can go a long way to resolving the pain.
I couldn't have said it any better. That's really a fantastic summary. And that people are not faking. It's not in their head. They're not crazy. They're just human. It's a human condition. Pain is part of the human condition. We need pain as an alarm mechanism. If you break an ankle, you need pain to tell you to stop, walking on that ankle. If you have a broken heart, you need pain to tell you, like, hey, you got it. We have to deal with what's going on in your life.
Have you received much resistance from other medical professionals, particularly those working in the pain management field?
It's hard to change a big ship. Big ships don't change quickly or deftly or easily. The medical world is a very big ship. And we've got research showing our model. We've taken that research to some of the major centers in the U.S. and abroad. But it's hard to change those big ships because that's what people are used to. That's what the patients are used to. It's a different model. Patients can be, as I mentioned, resistant or not understand the model. If you start to apply the model to somebody who doesn't think it fits them. They may be angry with the physician, and the physician hates that, so they don't want to rock that boat. That's all what their training is. I've talked to many practitioners, physical therapists, chiropractors, physicians, who are saying, well, what am I supposed to do now? Am I supposed to stop operating on all these people with back problems? Well, we have to change that. And the change is not going to come primarily from the medical world, I've concluded. The change is going to come from people with, as we say, who have skin in the game, people who are suffering, the people with pain, the people with these chronic conditions, because they're desperately seeking answers. And they're the ones online and finding these models. And hopefully the physicians will be persuaded by the research that we have. And we're doing 5 new research studies this year, in addition to the other data that we have. So it'll change. You can't keep a good idea down forever, but it will change slowly. I don't know if it'll be in my lifetime, frankly.
Well, you're on the 4th edition of your book, Unlearn Your Pain. It's a great read, and I think a real eye-opener for people, particularly if they have been struggling with chronic pain. As I said at the outset, 600 million suffering from chronic lower back pain alone. So it's an enormous problem globally. Dr. Howard Schubiner, absolutely fascinating to talk to you, and a privilege to have you on the podcast today. Thank you so much for your time.
Thank you so much. It's been a pleasure talking to you. You did a great job. Thanks.
Well, thank you for tuning into this episode of the Happy Habit podcast. If you enjoyed it or any of the previous almost 400 episodes, show your support. It's free. You can like, subscribe, share with other people who you think might have interest in these subjects too. You can leave the podcast a positive rating on iTunes or Spotify, and you can leave a comment over on YouTube and become a subscriber there too. Until next time, stay happy.